today. Dr. David Dooley will be talking about infections in the elderly.
Okay, it's late, so the handful of us here that are still here, I admire you and I compliment you for sticking around this long. And there's two rules to talking. One rule, of course, is the first rule. The second rule actually is to start on time. The first rule is to finish on time. And so I'm supposed to finish at 5, and so we'll kind of rip through this as fast as we possibly can. So we're talking about infections in the elderly today, and I want to remind you this has been a recognized difficulty as we move into our older age for a very long time. This is Shakespeare. As you like it, all the world's a stage, and all the men and women merely players, and one man in his time plays many parts, his act being 7 ages. And then there's 6 ages that are presented, from childhood all the way to middle age. And then the last scene of all that ends this strange, eventful history is second childishness and mere oblivion. Sans teeth, sans eyes, sans taste, sans everything. I want to present a case to you, a typical case, a 75-year-old widow admitted with weakness and ecchymosis, bruises. She had been admitted 4 months previously. This is a famous case, by the way. She had a nosebleed. She had weight loss. I'm going to go quickly through this. She actually was a foreign traveler. She had not much of a fever. She had some pancytopenia that you see there. They actually did a bone marrow on her. It looked normal cellular. But they put a PPD on her. It was positive. They thought she had aplastic anemia, and they gave her prednisone for aplastic anemia, kind of a high dose of prednisone, 80 milligrams. That was 4 months ago. 2 months before she's admitted, again, in the interim, she had traveled extensively. She had new leg weakness, which is why they brought her back in again. And she had new gingival petechiae, and her quadriceps were atrophic. They thought that was from her prednisone. But otherwise, she was the same. She actually had more neutropenia this time, although her platelets were up a little bit. The prednisone was dropped because they thought she was having difficulty with her muscles. Her final admission, her last admission, which is not a good sign then, right? She had worse weakness. She had more bruises. Now this time she did have a fever, and it persisted throughout the hospital stay. The platelets had dropped to 36,000. They admitted her. She was sallow. She was tachypnic. She did have that fever. This time she did not have a spleen tip. No lymphadenopathy. Her lungs were clear, but her chest X-ray did show streaky density. Her platelets were even lower. Every day she had temperatures of 105. She grew somnolent, more hypotensive, and on hospital day 9 she died. We'll come back to her case in a minute. Older folks do get more infections. Is that working? Yep. Older folks do get more infections, and this is all immune senescence. And you know, if you're involved with geriatrics, you know the word senescence as we all get older. And this is one of the things we're going to kind of cut through in the interest of abbreviating the talk. Cell-mediated immunity is waning. New cell-mediated exposures don't generate the same immune response. New B-cell clones that make antibodies are not developed, and I normally pick through this slide, but we're not going to today. Suffice it to say that, am I going to screw up that?
No, you can.
Suffice it to say that not only do your previous antibodies and your previous immune ability to things you were exposed to as a child wanes as you get older, but anything new that you're exposed to as you get older, you just don't have as rapid a response to it. And you can see this in vaccinations. If I vaccinate somebody when they're 2029, 100% of them actually get enough of an immune response, an antibody response, that we would consider them protected against both hepatitis A and hepatitis B. But as we get older, that drops remarkably, such that only half of people in their 70s, if I give them routine vaccination, this is the hepatitis B vaccine that all of you have gotten, and the hepatitis A vaccine that many of you have gotten, it just doesn't respond as we get older. Part of that is due to the fact that we don't have a thymus. Little kids have a thymus, you know, the big shadow on the chest x-ray of a 2-year-old kid. But that involutes as we get older, move into our 20s and our 30s, and by the time you're 70 years old, there's not even any residual thymus tissue, for instance, at autopsy. Older folks get more infections because they have more geographic exposures, they do go into nursing homes, they do go into hospitals, they get more medical procedures, and they have underlying illnesses such as CHF, such as swollen legs that give them more vulnerability. CHF is a culture media for streptococcus, for group A, for strep pneumonia. Why so many older folks get pneumonia and they get it with the pneumococcus. Why older folks get swollen cellulitis in their swollen legs? Because strep likes edema fluid. And so they have underlying illness in their legs in the first place, a series of previous episodes of cellulitis in those legs, and the strep just loves that and comes back again. Do they get, it's commonly said that older folks have diminished responses to infections. That's kind of passed around. Is it true? The answer is yes, it's true, and I won't pick through this either. This actually was generated in an ECTC, which I think was in Seattle. And they actually generated this. Older folks who did indeed have a diagnosed clinical infection were demonstrated to have a lower rise in temperature and a lower starting point. This is the lower rise in temperature here. They actually were proven to have infections, but half of them never broke 101. And a quarter of those that did rise actually still never broke 101, but they had a 2.4 degree rise, meaning that the starting point was down in the 97s. They come to you later. They have fewer and milder signs and symptoms and degrees of illness. They have non-specific, non-localizing symptoms assigned, especially mental status changes. For the physicians who take any internist who takes their medical boards, they always give you an old guy or an old gal that comes in with confusion at a temperature of maybe 99.8. It's confusion. And this is a presenting symptom of a pneumonia. Further down in the case, they say, we did a chest film and there's an infiltrate on the left, or examination shows, cellulitis on the right leg, and they want you to explain why the confusion is there. The confusion is there because of that. Just the mental status changes as a geriatric response to some infection elsewhere. Actually, the problem is it could be a geriatric response to anything elsewhere, can it? That's one of the difficulties. They have access difficulties. They can't get to the hospital. They don't drive anymore, and grandson or granddaughter can't get off work to bring them to the hospital. They are reluctant to present. They avoid coming in. They don't want to know the answers. And then lastly, they are frequently dismissed by us as having a UTI. So many of the older folks, especially in nursing homes, have pyuria. It looks like they have UTI. There's a 30% rule for nursing home patients. 30% of men and 30% of women have asymptomatic bacteriuria, that's ASP. 30% of those, however, will go sterile within a short period of time. 30% of the people that have what appears to be an infection with asymptomatic bacteria, after another month, those who are sterile will actually get asymptomatic bacteria. And if you decide to treat them, nothing happens. You don't improve anything. So at the end recommendation is you don't treat asymptomatic bacteria either in older women or older men. Okay. And then still, why older folks do more poorly with their infection, the law of parsimony is violated. They can have both pneumonia and they can have cellulitis at the same time. You and I at our age, well actually I'm getting older too, but a 25-year-old, when they get an infection, they're only going to get one infection at one spot. Okay? They have difficulty, we do invasive procedures on them. When we put things into them, we're reluctant to take things out of them. They don't tolerate the antibiotics very well. We'll talk about that near the end of the talk. And they have more interactions with their medicines because of polypharmacy. This lady I presented to you was Eleanor Roosevelt. Eleanor Roosevelt presented to Yale New Haven Hospital in 1961 This was actually presented in 1963 in a CPC, in the New England Journal. That was miliary tuberculosis I just described to you. They didn't make the diagnosis. They had lost that little piece of information about having the positive PPD when she came in. It never grew. Miliary TB tends not to grow. And they missed it. And the long parsimony also was, they saw her muscles wasting, and they kind of wondered, they said, well, that must be the prednisone. But it wasn't. She was just wasting. There was more than one thing going on in her, and that was a remarkable story, actually. Okay, we're going to talk about some of these today. Pneumonias, bacterial sepsis, prosthetic device infections, HIV infection. We're not talking about all these. These are all worse in older folks, but we don't have the time today. In older folks, abdominal sepsis can be terrible, and they have minimal symptoms. Surgeon opens them up, and there's just gangrenous in there. They can have minimal symptoms with abdominal sepsis. Odontogenic infections, same thing. Shingles. I put that up there only because there's an increased incidence as they get older. West Nile. West Nile is the summertime ache and pain, mental status changes, and low-grade fever in older folks. And can we do anything about it? The answer is no. But how do they do with it? They die. Older folks die. You and I don't. Well, I'm 60, so I'm getting there too. But if you're in your 70s and your 80s and you get West Nile, 10% of them die. It's really bad. This is the summertime aseptic meningitis, viral meningitis. It is a viral meningitis with confusion in older folks, especially older men, who sit outside and get bit by skeeters, because that's what happens in June, July, August, September. And they come in with the syndrome I just mentioned to you, commonly with a lot of peripheral neuropathy too. They got new numbness and tingling in their legs. It would be an astute clinician that can pick that up. It's not like we can do a whole lot about it anyway. Urinary tract infections, I'm going to avoid that today because that's basically too easy for you. Given the warning I gave you before about not overdiagnosing, we are going to talk briefly about antibiotic use in the elderly and vaccinations in the elderly. Pneumonia in the elderly increases as you get older. I won't spend any more time on that. Risk factors for community-acquired pneumonia, you're already also familiar with all this. This is a big one right there, especially in the inpatients, but also outpatients. Swallowing disorder, you know that, they aspirate. But also that, poor quality of life. These are separate and independent factors. Everything else being equal, but if you have a poor quality of life, it is an independent factor for getting pneumonia. For a nursing home, acquired pneumonia, profound disability, older age, and again, the swallowing disorder, none of that is new to you. These are the etiologic agents, and none of these also are a surprise to you. Strep pneumonia, Haemophilus influenza. Staph aureus is there, and Staph aureus is there. So as an outpatient pneumonia, Staph aureus is still an issue, and this can be both methicillin sensitive, but also methicillin resistant Staph aureus, such that when we have patients coming into the hospital, especially if it's in flu season in the wintertime, because staph loves to come on top of flu. So December, January, February, one of the automatic things we put people on, older folks or younger folks, if they come into the hospital with a purulent pneumonia, we put them all on vancomycin. Because so much of that pneumonia is MRSA, on top of staph coming on top of viral influenza, not Haemophilus. Haemophilus influenza, which actually the bacteria got its name because it came on top of viral influenza back in the 17 and 18 epidemic, when we realized most of those patients were dying of that germ on top of the virus. And then hospital-acquired pneumonia, gram-negative bacilli, Staph aureus again, polymicrobial, and still really a lot of strep pneumonia after they've been in the hospital for a while. Predictors of bad outcome, this is the curve 65. Numbers, actually a disability is not one of the curve 65, but as they go down, that's a predictor of bad outcome. Confusion, higher age, that's a 65 in curve 65, the greater than 65. Every one of these, like as you click off these on a graded level, every one of these doubles or triples their mortality rate. If you only have one of these, you have less than a 5% mortality rate. If you have all of these, all curve 65, C is confusion, U is uremia, the serum creatinine greater than 1.4. R is respiratory rate greater than 30. B is blood pressure less than 90 systolic. If you have all 5 of those, you're at greater than 50% mortality if you come into the Very briefly, I'll touch on this. The non-responding person with pneumonia, or when you get the x-ray that comes back when you first see them, if you see these changes, this doesn't come through well. I have lights on up there, but this is smudges in this apex, smudges in this apex. That's TB. TB is not going to respond to the antibiotics that you actually give these patients. So the non-responding patient, or the patient that you first see on the very first x-ray with abnormalities there, or the patient, the non-responding, or when you first see that has a lung abscess over here. You're going to treat these people with either a quinolone or as an outpatient, or with a cephalosporin and plus minus maybe azithromycin or clarithromycin. There's nothing, that lung abscess, the aspiration, they have swallowing disorder, they aspirate, they get aspiration pneumonias. That aspiration pneumonia, the lung abscess, is not going to respond to your antibiotics. We're going to jump over to bacteremia quickly. It's the same lack of symptoms and signs that I mentioned, globally for all infections. There's the same increase in mortality in the elderly. Below age 65, to greater than age 65, 15% up to 30% mortality if you find Staph aureus in blood, and MRSA is bad. It doubles your mortality. That's in older folks and younger folks, but you can ratchet it up even more in older folks. Let's talk about prosthetic device infections recently. This is the big thing, and many of you who are working down in the CLC or with geriatrics, besides, know that so many of your patients have various prosthetic devices that have been put into them. Many of them, once they get in, obviously get infected. The greatest number of them are joints, but these other implantables are in penile pacemakers, IVCDs, CSF shunts, like on a Meyer reservoir, pain pumps, like the ones that are put in up and just either a pain pump or a pain electrode put into the spinal cord for chronic pain, or the vascular access ports, especially the ones that are hard to pull out, the porticats. Pick line, I can pull out in the next 30 seconds in here, but you got to send somebody to the OR to have a porticat, for instance, pulled out. So these are actually, they tend to be problematic. They tend to, almost all of them get infected at the time of implant. It's not what you do working on the patient later on. They tend to be infected at the time of implant. Well, if you access, for instance, a line, if you access that in less than sterile fashion, yes, you can contaminate and you can get infected. But generally they get infected at the time of implant by staph or gram-negative rods or candida. Rarely, actually, that you can see to them bacteremically. Somebody's got one of these things put in, you find that their doctors find Staph aureus in blood, and then 3 weeks later they start to have pain at that site. And you aspirate from that site, you find Staph aureus in it. That is an uncommon story, though. The approaches in the elderly are problematic, especially for joints. If they're not joints, we almost never sterilize them medically. And if you leave them in, they actually have higher morbidity, and if it's a joint, actually, they have higher mortality. Ultimately, we really have to pull those out. It's very seldom that you'll see a pacemaker that's been infected that will agree to leave that in. Very seldom you have an IVCD that we agree to leave that in, a porticat that we agree to leave that in on an older person. Rare. But what is not rare is this: if you get an arthroplasty, if they have a metal hip, a metal knee, and they're 80 years old, and there was a major thrash to put that in the first place, commonly, if we come and see that, and as an infectious disease guy, if I come and see that patient, and we can quiet that thing down with antibiotics, first intravenous, maybe over to oral, we may give that guy suppression forever just to avoid an 80-year-old guy going back to the operating room and having his knee taken out. So it tends to be the big joints tend to be problematic because it's not an easy thing to put them through another arthroplasty. HIV infection, I want to touch on this just for a second, but I do want to lay it in front of you. For the longest time, everybody with HIV infection was all in their 20s and 30s. 20s and 30s, gay men or shooters, IV drug abusers. But for a long time now, the last 15 years, 10% of our race patients have been older than 50. Right now, my average age in my clinic is 58 of my 60, 70 age patients that HIV-infected patients that I follow. And it's because they generally are doing well. We have an accumulation of slow progressors, people whose immune systems control it well anyway, even if I didn't give them any HIV medicine. But on top of that, our HIV medicines are very good. They do have an increased mortality when they're older compared to those that are less than 50. They do have their medical comorbidities, they have polypharmacy, and they do get adverse pressures. And they have late diagnosis. Nobody thinks to get an HIV ELISA on an 80-year-old guy. Nobody thinks so. Who are most of these guys? They're mostly guys. And most of them are gay. Many who have sex with men. Many of them are IV drug abusers. Many of them have heterosexual. But look at this, a quarter of them, there's no risk reported. And that's because an 80-year-old guy doesn't want to tell you that he had gay contact 20 years ago, or that he was shooting 20 years ago. That's where that comes from. And the other thing is, how do they present? They present with this. It's a striking thing. That is actually a neat CPC in the New England Journal. I commend it to you. But they come in with dementia, and they tend to be a little bit more rapidly progressive dementia. Dementia more common and more rapid. They tend to be more depressed with their dementia. But for all purposes, they just called somebody that has Alzheimer's disease. And it's so much so that, frankly, the evaluation of new dementia in an older person used to be the catch-all. Unless we get a TSH, we get a vitamin B12, we get an RPO, right? We've got to have at least one of those in your back pocket. Well, now we ought to have all three of those and an HIV ELISA. Okay. Okay, so we've left the major syndromes, and we're just going to go over and talk about two other categories: antibiotic use and vaccinations. How am I doing time?
Great.
In general, you can use almost all antibiotics. I'm going to give you warnings about a few, but you have to watch them very carefully. The most useful are the beta-lactams, penicillin, cephalosporins, carbapenems like imipenem or meropenem as an in-hospital, or X3 in hospital. But as an outpatient, either any of the penicillins or the cephalosporins. Why? There's such a high therapeutic index. You can reach really high blood levels either orally or intravenously, and still they have no adverse effects. There's so many of them, so many of the antibiotics that you actually give the drug to, and by about the time that you're reaching blood levels that are starting to work against the bugs, they're also starting to get adverse effects. That's the narrow therapeutic index, and aminoglycosides are a good example of that. These are the greatest concerns. Number one is that the serum creatinine does not reflect the true creatinine clearance. You know that, I know that, anybody who works in the field knows this. An 80-year-old man with a serum creatinine of 1.3, which in maybe you and me would be fine, he or she has a creatinine clearance of 25. So you can greatly underestimate their degree of impairment, even with just a little bump only a little bump in the serum creatinine. And then next, of course, their polypharmacy with drug interactions. I look at least every day, at least every the afternoon when I see my patients. I only see about 5 HIV patients and 1 or 2 infectious disease consults on Tuesday afternoons. At least one of my HIV, if not 2 or 3 of them, has more than 25 concomitant medicines. And I look all of them up on the drug interactions up to date. Okay, so you adjust for renal clearance. You assume you're going to adjust for renal clearance for all of them. Shade it down a little bit. Don't give them quite so much, except for these. The anti-staphylococcal penicillins, nafcillin, oral dicloxacillin, you probably don't use that much anymore. If you can use the cephalosporin, you tend to use Keflex, for instance. So those are cleared through the kidneys, and so rather than giving 2 grams a day of Keflex, you may want to give 1 gram a day, or 253 times a day, for instance. Ceftriaxone is not intravenously. Ceftriaxone is not cleared through the kidneys. It's only cleared through the liver. You can give all that you want. You can give all the clindamycin and all the doxy you want because these are all cleared through the liver, not the kidneys, and you don't need to worry about it. Here's problematic adverse drug interactions, and these are problems. I can't remember a time when I gave an aminoglycoside to anybody older than about age 65. I can remember times a long time ago when we were using a lot of aminoglycosides, gentamicin, tobramycin, amikacin, and I would come by to see the patient famously on the orthopedic service for a gram-negative infection in their hip, and they're gone. And I said, where'd he go? So we sent him out to a nursing home. And I said, well, who's going to follow them for the, oh, no, don't worry about that, Dr. Dooley, we got it covered. The nursing home IV people are going to take care of that. And then the person comes in a month later and they have total kidney shutdown because they lost control of the aminoglycoside dosing, or they're deaf, or they have so much vertigo from the aminoglycoside that they'll never hear again, or they'll never walk again because their vertigo doesn't go away. That's what aminoglycosides would do to older folks. These three, quinolones, metronidazole. So quinolone is levofloxacin or moxifloxacin. We just left moxi to go over to levofloxacin as our quinolone here in the hospital. Metronidazole, which is flagyl. You guys give flagyl, oral flagyl and or intravenous flagyl. And linazolid. All three of these can make them go wonky in the head. You can watch them go wonky in the head. You need to shade each one of these, the doses of each one of these down lower. Metronidazole and quinolone especially. And then these three, actually, you should worry about with C. difficile infections. Let's see, in the last 5 people, let's see, in the last 6 years, 5 people I've watched die with C. difficile who were older than 62, 65. Older folks just do poorly. And that's my anecdote, but that has been shown over and over again in the literature. Older folks do much more poorly with C. difficile infections. And, boy, I can't remember a time when I've agreed to give clindamycin to an older person. This is the big dog right there. Quinolones are the second big dog. Beta-lactams are the third, and so I'm beta-lactams. Penicillin, amoxicillin, augmentin, cephalosporin, you betcha. Every one of those. So I give a lot of that. I give that to old folks before I give that to old folks. But I'm still nervous, and I tell them, you start to have diarrhea, you need to call me. You need to tell me. I've got to get them off of it quick. Coumadin with all its interactions, we won't get into that. Quinolones and tetracycline. I don't need to get into that because essentially, as you know, older or younger, anybody you put on Coumadin, if you don't know, if you don't remember, you should look up the interactions. Coumadin is the most dangerous drug from that point of view. Quinolones and tetracyclines are absorbed poorly with cations. What's all this stuff? This is all stuff in multivitamins. You give all your older folks multivitamins. So you tell them they have to take their quinolones or their tetracycline at another time from their multivitamin. Just don't take it at the same time. Bacterium elevates of serum potassium. Don't get fooled by that. And then outbreaks in the elderly. Famously, I'm sorry, 2 more topics, but only a couple slides each. Famously associated with long-term care facilities, viruses occur in the elderly in the long-term care facilities, especially flu. We're going to come back to that. I'm sorry, this is what I need to say right here. Influenza in a long-term care facility, including the CLC, including anywhere in nursing homes on the outside, is most effectively prevented by the nursing home healthcare workers being vaccinated, not the patients being vaccinated. If I had 50 people in the nursing home, patients, and 50 healthcare workers, and I had 50 doses of influenza vaccine, I'd give all 50 doses to the healthcare workers, and none of them to the patients. That's more important. It demonstrated empirically, people just watch that, and demonstrated experimentally. It's been shown. Okay, they do get the typical germs, but TB actually is a famous thing in nursing homes, and people grab their head and say, somebody's been in there coughing for 3 months, and then they turn out to have tuberculosis. Everybody in the nursing homes has been exposed to it. So that's why everybody going to the nursing home gets their PPV put on, their TB skin test. You do get gastrointestinal viruses that rotate around. That's not good. You and I may get the poops for 4 days with norovirus, but older folks are going to die with this. They'll get dehydrated and they'll die. These bacteria do go around nursing homes, famously staph, Clostridium, Bacillus cereus, are on foods that are not adequately heated or not adequately refrigerated. Bacillus cereus is a Spanish rice type of food. C. difficile with the antibiotics, as I mentioned to you, and even these parasites that they can be exposed to in nursing homes, caught usually from other people. Amoebiasis in particular, from other people. Giardiasis, you actually get, and cryptosporidiosis, they actually get from the fluids that they drink, water that they drink. I mentioned influenza vaccine in the elderly. The influenza vaccine keeps them from getting pneumonia, keeps them from dying pneumonia, and interestingly, they get less cardiovascular disease to include heart attacks, strokes, and all-cause death. This is an interesting study. It's like my third to last slide. This is a study published several years ago in Russia. There were 2 towns. And they had X amount of vaccine, and for some reason, the Russian government, this is not an experimental study, they just randomly gave all the vaccine to one community, and all the kids got it. And then they did not give the vaccine to a nearby town, which actually was very closely matched. And so nobody in that town got it, no kids and no grown-ups. And then they compared the relative risk of these syndromes. That's influenza-like illness. So here's the influenza. But that's pneumonia, that's asthma, that's COPD, that's cardiovascular disease, that's diabetes. And this is the relative risk of an exacerbation in this. There's COPD, the relative risk of old folks having an exacerbation of COPD when the kids are vaccinated over the winter was 1.7 of asthma exacerbations, of pneumonia, cardiovascular disease, them having heart attacks. This was a great study. It's a fascinating study in Russia, but we've demonstrated that here in the U.S. as well. There's a higher incidence of people, of older folks, dying of heart attacks in the middle of their influenza than if they don't have influenza. It makes sense. They're under stress, right? But what this one shows you is the effect of the flu vaccine. You can actually prevent it. It was a fascinating study. The pneumococcal vaccine is not quite the same. You don't really prevent bacteremia that much. You don't, but it's a little bit, it's not much. Pneumococcal meningitis, a little bit, not much, but it's significantly, the pneumococcal vaccine does keep you from dying from those. It doesn't prevent you almost at all from getting just regular old pneumococcal pneumonia. But it helps against these worser ones, and it really helps against dying. Well, I mentioned that. Well, I'll point this out. What does it not protect against? Pneumonia caused by anything else. Most pneumonias are not caused by pneumococcus. So you'll get patients that come in and tell you, I don't need that pneumococcal vaccine, that pneumonia vaccine. I took that and I still got pneumonia. So, yeah, that's because it doesn't really, you're still alive, number one. If it was pneumococcus, it kept you from dying. But the chances are, given old pneumonias, most pneumonias are not pneumococcus, you probably had something else that vaccine wasn't designed against. All right, immunizations in the elderly, just remember to give them. You should have systematic solutions. What's the systematic solutions that you're involved in? Every time they come into your place, you review it and you give them the vaccine. Can you under-vaccinate people? No. I'm sorry, yes. Can you over-vaccinate people? No. Okay? In other words, if you think to yourself, oh, this person may have had the pneumovax, and you look through the record and you don't see it in there and say, oh, I just don't want to give it to them because they might have had it before. No. Vaccinate them. And that's what our policies say, actually. That's wisdom. Okay? Immunizations, half of tetanus cases in the U.S. occur in those over age 60. Almost all of these are not, quote, up to date, meaning, having had that vaccine in the last 10 years. They're 30, 40 years old. And that's why half of these cases occur in people older than 50. There's the zoster vaccine. Should be given to anyone over than age 60 at least once, no matter whether they had prior shingles. They had shingles 2 years ago. They said, I don't need that. Well, yes, they do. You'll drop them you'll drop their chance by 50% still, or their post-herpetic neuralgia by 70%. Those of you who are taking care of previous shingles patients with post-herpetic neuralgia, you know they really don't like it. And it's a problem that's very hard to treat. Okay. That's my time. That's it.
Great. Perfect.
Yes, ma'am.
Which antibiotics then are usually recommended for?
So the beta-lactams with the same caution that I just gave you. If you're going to give a beta-lactam, well, okay, it depends. It does depend upon the syndrome. For skin and soft tissue, you would still probably mostly go with Keflex as a cephalosporin. When I say skin and soft tissue, a cellulitis. If it is a cellulitis with a lot of pus, in other words, it's abscesses, more abscess with a focal collection that looks like it's going to drain pus, rather than a spreading cellulitis, the kind of cellulitis you see on the lower legs that comes up the leg. The spreading cellulitis like that is usually strep. I'd give that one Keflex. A local abscess like that famously is staph, and that person, your chance of it in the community or in the hospital being MRSA, and therefore resistance to the cephalosporin, the chance is pretty high. So we often tend to give those guys Bactrim or doxycycline because they're almost uniformly active against MRSA methicillin-sensitive Staph aureus, and MRSA, methicillin-resistant Staph aureus. If it's really bad, you bring them into the hospital. What if they got pneumonia? You got pneumonia. Keflex doesn't cover pneumonia very well, and if you wanted to treat them with something, you can treat them with a low dose of fluoroquinolone. How much would I give an older person, of normal weight, not an obese older person? Most obese people don't get to be older persons. I would give them, like, say, 250 of levofloxacin, not 500 or 750, which you and I might take. You got another question?
What is MISA?
Methicillin-sensitive Staph aureus. Staph aureus that's not resistant to Keflex. Okay. There was another question over here?
There's one other quick one. Can you, for the pneumonia, if you give a second dose, is it harmful then? If they didn't know that, they got a first, but they got a second pneumonia shot.
If it's
They've got one before, but they get another one a year later or 2 years later, is that really harmful?
well, there's two scenarios that I would address. So if they got an antibiotic before and they did not have an allergic reaction last time, you don't need to worry about it this time.
Pneumonia vaccine.
Oh, the vaccine. Oh, okay. Well, I'll mention the antibiotic too. That's an interesting thing too. No, the pneumonia vaccine the pneumonia vaccine we've had for a long time is the polysaccharide vaccine, Pneumovax. That is pretty strong, and you're supposed to give it at least the once and repeat it at 5, 6, 7 years, somewhere in there. We have a new vaccine, and you've seen that one that's come out. That is a protein conjugated vaccine. So it's PCV13 in the order list. If you never had a pneumonia vaccine before, you're supposed to get that one. If you had the old-fashioned vaccine before, you're supposed to go ahead and give that vaccine, the new one, the protein one. Actually, wait a minute, let me get that right. If you never had one before, you're supposed to get the polysaccharide vaccine first, and then the protein vaccine after 6 months, a year. You're supposed to wait and give the second one as a boost after a short period of time. But we do have that new vaccine, and it is a better vaccine. Clearly, if they had, I thought you were addressing antibiotics, but let me mention something else to you. So if you got Keflex 2 years ago and they had no problem at all with it, of course they can get Keflex again. What if they got Keflex 2 years ago, they had a rash, and it was entered into your computer as allergic to Keflex? And they went home, and or they're in a nursing home, somebody comes along and gives them Keflex. And now they come to you, and it's 4 days later, and they're doing fine. What do? You keep giving them the Keflex. Something else happened a year ago. One or two things happened. Either it wasn't the Keflex that we're allergic to a year ago, or number two, they may be allergic to it. Maybe they're going to get an allergic reaction, but it's going to be so mild that it's not going to be an overwhelming allergic reaction, and you should just watch them and continue giving them. It doesn't mean I would give them the Keflex if they're sitting in front of me and they haven't been re-challenged with it. If it says Keflex in there and they haven't gotten the new drug, the drug the second time, I wouldn't give them to it, but it's a frequent scenario, am I right? That they have a drug allergy in there, and you come by and you see them, and they've been on the drug for 5 days with no adverse effects. So those people, we continue to give the medicine, and we just watch them close and use our judgment. Anything else? Thanks for your attention. I admire all of you for sticking around with me.